Sir, we are live now.
Okay. So, good evening, everyone. All those who have joined us, joined this fellowship, and also all those who are seeing this on OrthoTV. So, today's session is the first session of the third virtual online fellowship on osteoarticular infection, which is mentored by Dr. Vikas Agashe, Dr. Anand Thakur, and Dr. Aditya Menon. This session is also made possible by Biocomposites, the maker of Stimulant, by an academic grant. With this, I hand over to Dr. Vikas Agashe to take over the session and proceed. Thank you.
Hello, good evening all. Can you all put on your videos, please? I request all of you, please put on your videos. Please put on your videos.
You can
Dr. Kapil, Dr. Sandeep.
Yeah, even if you are in your OPD, just put on your videos for some time at least.
Okay, sure. So please, all of you, put on your videos. Can you see my presentation?
Yes, sir. We can.
Yeah, it's 9 o'clock. So good evening, friends. Welcome to this third fellowship on osteoarticular infections. We're really happy that all of you have decided to join because, the orthopedic infections are really increasing and becoming very complex. And it is said that no care today, there is no future tomorrow. Tomorrow, you will have no future for even routine orthopedic surgeries if we don't take appropriate care. Now, the very common statement of an Indian is somebody should do something. Somebody should do something for infections. Now, let's play some friends that somebody is we all. So let's join hands in the war against osteoarticular and soft tissue infections. And let's start with the introduction of delegates, participants, faculty. In fact, I would call all of you faculty because we are going to have interactive sessions. So, Dr. Raghavendra there? He's from Telangana, practicing since 10 years. I saw Stavan Amin there. Stavan, can you?
Yes. Good evening, sir. Good evening, sir.
Good evening. Good evening. So just a few words about yourself and then what do you expect from this fellowship?
Sir, I am a senior resident right now doing my residency at JJ Hospital. Done with my master's last year. So yeah, I am sir expecting to learn about infection and how to be better at treating them in my cases, in the cases we do over here.
Okay, nice that you are joined. Dr. Bhavya Chanda?
Yes,
Bhavya
sir.
Chanda, I think you are there, right?
Yes, sir.
Yeah.
Hi, sir. Good evening. I am practicing orthopedics for the last 9 years, sir, near Dwarka Tirumala in the state of Andhra Pradesh for a trust hospital by name Word. It's like Bird Tirupati. We do have Word at Dwarka Tirumala. We do have a lot of osteoarticular infections, arthroplasty mostly. There's the reason I'm asking to include one session of arthroplasty infections also in this meeting. And I want to improve my basics in this infection, what are the protocols to follow, what else to do.
Correct. Great.
Thank you, sir.
Thank you, Bhavya. Shahrukh is there? Shahrukh is probably not there. He's a senior resident, as you can see all this. Sports Injury Center at Saftarjung. Rama?
Sir, hi. Good evening.
Yeah.
Yes, sir. Good evening, sir. This is Ram Karthik from
Good evening.
Andhra Pradesh near Vizianagaram. I've completed my MS Ortho and I did my fellowship in Ilzara at Kurgan. Hello, sir. Yeah, my center is a referral center for infections, sir. So I'll do more of infection cases only. So it's just to upgrade my knowledge and unlearn and relearn to do it better.
Unlearn and relearn. Very important statement. So friends, he has said something very important. What is learning? Learning is learning, unlearning and relearning. So thank you for that, Ram.
Sir.
Sandeep there? Fantastic
Good evening,
photography
sir.
from Himachal Pradesh. I think he's must be expert in skiing. Sandeep, you there?
Yes, sir.
Yeah. Can you just put on your video?
Trying to learn it, sir.
Sorry?
Am I audible,
Yeah.
sir? Good evening, sir.
Good evening. Good evening. So tell us something about yourself.
Sir, I'm working in a government medical college as a professor.
Right.
And right now I'm on vacation trying to learn skiing.
Oh, great.
And this fellowship I joined because I feel it's a very important topic for any orthopedic surgeon to deal with the infection in the bone and joints.
Thank you, Sandeep. Ankur there?
Thank you, sir. Right, sir.
Yes, I can see Dr. Ankur is logged in. Dr. Ankur, could you unmute yourself? Probably not
Anyway,
there.
he's a private practitioner at Mittal Hospital, Haryana. Vani Ahuja or Vani Ahuja from Bangalore. There?
No, I can't see the names.
Okay. Okay. With that, I will introduce the faculty very briefly, and we'll have detailed discussion as we go along. So the senior most of us, Dr. Thakur, and I'm sure you must have read his books. It is said man is known by his company, but Dr. Thakur is known by his books. And he and myself and Dr. Menon will be basically managing this fellowship. But of course, we will be greatly helped by several faculty members. Dr. Bimal Modi, who is a plastic and reconstructive surgeon. Dr. Samir Dalvi, who is a spine surgeon. Dr. Sanjay Kulkarni, microbiologist and infectious disease consultant. And he would be basically telling us about prevention of infection in theaters and in the healthcare system. That means autoclaving, cleaning the theater. So he'll cover all that very, very important topics. Then we have two infectious disease specialists who would from next time onwards one of them will join and discuss about antibiotics in each and every case, because that is something I mean, it is said that an orthopedic surgeon knows only two antibiotics. One is augmentin and second is gentamicin or maybe amikacin. That's all. So let's go beyond that. So one is Dr. Aisha Sunawala, who is a consultant in infectious diseases, and Dr. Mandara Gashi is a pediatric orthopedic surgeon, and Dr. Umang Agarwal, who is the other consultant in infectious diseases. And last but not the least, we must know a bit about microbes. In fact, every orthopedic surgeon should know at least something about the world of microbes, and Dr. Shauli Basu will be discussing with us. So friends, your ideas about format of fellowship are most welcome, but what we have planned is we are planning to have 10 sessions, which will be virtual every Friday at 9 o'clock. Duration would be about 1.5 hours. And then that would be somewhere in between. We will have a physical session of 1.5 days. we would very much like these to be interactive sessions. So we would definitely not prefer people just shutting off videos and then disappearing. We must have interactive sessions, not only amongst faculty, but within the entire group. So as I said, you all are faculty. All of you are senior enough to be faculty. Essentially, it would be a case-based discussion. So please do send your cases for discussion and suggestions. And something all of us Indians like, and that is ask questions, give inputs, disagree strongly, debate, fight, but let it be in a civilized manner. But remember, there are several ways to success or more probably to failure. And what is important is we must respect differences. You can't just say, oh, that is bullshit. So I'm sure you all will not do that, but let's respect a person who has a different, totally diagonally opposite opinion. Please keep your audio on mute, but do unmute time and again when you want to give inputs. And but keep your videos on. Now, yes, biocomposites have supported this, but remember the discussion will be balanced and purely academic, and they are very, very clear that they are helping us in our movement against osteoarticular infections and not promoting their brand. They're helping us in this movement against osteoarticular infections. So let's now, with that small introduction, let us start with the first session, and that is retain or remove implants. And Dr. Aditya, could you just read out the survey results?
Yes. So before we step into that, there are a few other doctors who had not put their details on WhatsApp group, but they're here. So if we can just ask them to unmute. And Dr. Raghavendra is here. Dr. Raghavendra.
Yeah, sir. Hi.
Hi.
Good evening.
Hi. Good evening. So if you could just tell us something about yourself in a couple of lines, we would be happy to hear that.
Yeah. I'm an orthopedic surgeon, sir, practicing in Nizamabad, located in Telangana state. I'm practicing since last 10 years, and I do most of the trauma cases. And I have done fellowship in orthoplasty, and I do joints also.
Thank you. Thank you. Thank you for joining this, and we hope to make this worth your while.
Yeah, thank you.
I can also see Dr. Dheeraj here. Dr. Dheeraj, if you could unmute yourself. Okay.
Yeah, sir. Good evening, sir.
Yeah, hi. Good evening. Hi. If you could tell something about yourself, Dr. Dheeraj.
Yes. Yeah, sir. I'm practicing in Pandharpur. That's in Solapur district. And I passed out in 2010. And I'm doing private practice.
Okay. Welcome, Dr. Dheeraj. Thank you.
Yes.
Thank you for joining us. Is there anyone else that we have missed out?
I think Mittal, Roshan, you there? Ankur Mittal Ankur Mittal, are you there? Okay, if there is no one else,
Dr.
let's
Chinmay?
start with our session on retain or remove. So, Dr. Menon, can you just tell us about the survey?
Yes, so we've done a short WhatsApp poll on how to manage early implant-related infections. So how often, we'd asked, one question was, how often do they manage? So we've got 6 answers, 3 being very often and 3 being sometimes. So it's something that is seen once in a while, at least by almost all orthopedic surgeons. The second was a more clinically relevant question where are the doctors aware of any guidelines? And if yes, how easy is it to implement in real world? So far, we've not got any answer saying yes, they're aware and very easily being able to implement it. There were two who are aware of it, but find it difficult to apply it to their patients in the real world. And the others have said that they would want to know more about these guidelines. So I think it's a very relevant topic in the real world, sir. So if you could go ahead with that, I think it's something that everyone would want to hear about.
Okay, so let's start with the first session. I had mailed you, rather sent you on the group, a small PPT showing these two cases. And
It's not on slideshow
you can
mode.
see they're almost similar. This is a young man with
Sir, it's not on
infection.
slideshow mode. Sorry.
Yeah, sorry. The young man presented with obvious infection and showing a bipolar plating. Another middle-aged person presented with infection and bipolar plating. So we will discuss this particular topic, and with the help of these two cases. And so I'll start with the first presentation. Yeah. So at the outset, I must thank our multidisciplinary team, and then let's discuss this case. This was a young man presented on 15th day after osteosynthesis. So take you back in time. He had a vehicular accident and he sustained apparent tibia fracture. You can see it's a markedly comminuted fracture. The soft tissues are very poor. Fortunately, there was no compartment syndrome, no distal neurovascular deficit. So the index surgeon, he was in a small place, and therefore the index surgeon decided to do an external fixator and shift him to a major center. So he shifted him to another center, and this is the CT scan with 3D reconstruction. You can see it's a really complex fracture, and the soft tissue envelope certainly improved after external fixation. Now, we all know span, scan, and plan. So the surgeon did the scanning, and now it was time to plan and execute. So this was operated in another major hospital. You can see at 2 weeks, the surgeon has done open reduction by medial as well as lateral approach. And that's the medial after putting a medial plate. And that is after posterior medial plate, a lateral plate, and an anterior posterior screw. You can see it's a achieved very good reduction and stability. Now that's the post-op X-ray, and unfortunately, at this stage, you can see he has got a significant discharge and a redness. Now what do I do? What will be your plan of action? I am stopping to share, and I would like at least two of you to start the ball rolling. Kapil, can you unmute and can you tell me what will you like to do?
I'm not a professional doctor, but still, I would like
Okay.
to, I would like to consider this to, first look into the discharge, and maybe if there is a possibility to take a sample and start with some IV antibiotics.
Okay. So you'll take a sample from outside, take a swab,
Yeah.
and start IV antibiotics.
Yeah.
Right. Now, anyone else? Raghavendra, will you like to chip in?
So it depends upon culture and sensitivity, what Kapila said. And
Right.
if the infection settles and the ESR, CRP, if it settles with IV antibiotics, I'll be happy. Otherwise, I'll go for again implant removal.
Implant removal. So last question to Amin. Amin, would you like to say something? Yes, please.
Sir, I would first get a sample from the like a cultural sensitivity first, sir. Start him on empirical broad spectrum till the result comes back, and also will follow up on ESR and CRP, do a serial ESR and CRP to see the progression.
Okay.
We'll try to treat with antibiotics first, sir, initially. Definitely.
Okay. Fine. So
and try to retain the implant, sir, as much as
you
possible.
try
sir.
to retain the implant.
Yes,
Now, Dr. Sandeep,
Sir,
what would be your line of action? Now, he has
sir, I
carried
think
a report. I will just share that report. Culture sensitivity is already there.
yes, sir.
And that's the culture report.
Sir, possibly I will open
That's the culture report. Highly resistant
Yes, sir.
Enterobacter cloacae complex. You can see it's resistant to almost everything except tigecycline, phosphomycin, colistin, and so on and so forth.
So this is Dr. Ramkartik here, sir.
Sir, I will do the radical debridement. Number one.
So,
regarding retaining of the
any
implant,
input? Can you please speak loudly? I can't hear you.
Sir, I'll do the radical debridement. Number one. Implant, I'll try to
I can't hear you.
retain.
I'm sorry.
Am I audible, sir? No.
Yes, just about.
Sir, I'll do the radical debridement. Number one.
Radical debridement.
Implant, I'll try to retain. Implant,
Yes.
I'll try to retain.
Yes.
The wound closure, either I'll be doing with the antibiotic cement or I'll use a vac for the time.
Yes. So
and that
he
will be
would like to do a radical debridement. Am I right?
Yes, sir.
Correct. Okay. Anything
After
else?
the debridement,
Sir, Ramkartik here, sir.
Yeah.
Hello? Yeah, sir. As there are very less bullets to shoot the bacteria, I don't like to retain the implant and take risk. So I would like to exit the implant, keep him on and attain the congruity and length, keep him on some form of action fixator and thorough debridement. Then wound coverage, sir. That is my choice. And local antibiotic delivery system.
Okay. So we have diagonally opposite opinions. Sandeep would like to retain the implant, do a radical.
sir, I'll try to retain the implant.
And Ram would like to take out the implants. So let's see what.
And so there's a third opinion of pure antibiotics and not touch the implant right now. So there are three dimensions.
Pure antibiotics. So antibiotics guided by culture, we already have a culture, right? So the first thing is, how do you rationalize what to do? And this is one publication which is phenomenal. I think it is one of the best publications I have read in last many years. And I strongly urge you all to read this publication. Fracture-related infection, role of surgeon and surgery in prevention and treatment of fracture-related infection. And they have introduced a totally different concept, what is called SOSTAC model. Now this SOSTAC is actually something which was introduced almost 25 years ago by one P.R. Smith, and that was related to marketing. And this SOSTAC stands for S is situation analysis, O is objective, S is strategy, T is tactics, A is action, what is your plan, and C is your control. What do you monitor? This is classically introduced for marketing, but the authors have said that this actually would work for fracture-related infections as well. And we will discuss our cases, both these cases, based on this model. There's a little modification by me because I feel that H is very, very important. That is history. So let's start with the history. Here the fall from motorcycle, high velocity injury. Soft tissues, extensive soft tissue injury. Wounds communicating with fracture, open fracture? No. What are surgeries were done prior? He had an external fixation, he had a medial and lateral approach and bilateral plating. When was the infection suspected? 2 weeks post-op. And debridement was done by the primary surgeon. So 2 weeks post-op, he suspected infection and he opened the wound and took cultures. Now, surgical treatment after suspicion of infection, yes. He has done exploration, debridement, and he started on colistin. Microbiology, he has a highly resistant enterobacter, and which is ciprofloxacin resistant as well. We'll discuss the significance of this ciprofloxacin a bit later. He's on colistin, and when did the patient present to us? On 18th day. So what is situation analysis? That is, consists of 6 things: host status, implant, state of fracture, microbiological diagnosis, condition of other structures like nerves and vessels, and movements of joint and function of the limb. Now, each one as regards host status. He has no systemic comorbidity, young man. Local comorbidity, nothing. Excellent function previously. And does he have social and economic support? I mean, that is very, very important because it would take a long time for addressing such things. Now, as regards implant is concerned, we have an excellently, properly placed implant. Time elapsed is 18 days only. Do we have intramedullary implant? Because it is very, very difficult to clean the implant. Do a proper debridement. No, I have a plate which I can open and clean. Are there any combo structures, plate and nail, or things that are difficult to debride? No, I have a plate which I can debride. Now, what is the state of fracture? I have a proximal tibia fracture, and therefore soft tissues are going to be a problem. My reduction is good. I mean, it is done by index surgeon, not me. It is too early to say whether it is consolidated or not. And there are no bone defects, right? Now, coming to microbiological diagnosis. What do you mean by that? First, you have to locate the microbes. You need to identify them. Now, both these things have been done. However, I'm not too sure whether localization underneath the plate is done, and it is difficult. How will I be able to reach with my antibiotics and my knife? Yes, I have. They are reasonably superficial. I can explore, debride them, and I also will have a good blood supply. So my antibiotics will reach. Is it possible to kill them? Yes. And can I avoid further infection? Yes, if I can achieve a good soft tissue cover. Now, this is all fine, no nerves involved, no function of limb is fine. So then comes to objectives. What are your objectives? Where do you want to be? I want everything. I want to achieve fantastic result in him. I want infection control. I want soft tissue healing, fracture consolidation. I obviously want prevention of chronicity and good function. But at the moment, what do I want? I want infection control and soft tissue healing. Correct? So how do I do that? My aim is to do a good DAIR. That is debridement, antibiotics, and implant retention. That is my first and foremost thing. As regards my actions are concerned, I must do a good DAIR. Now, what do I mean by good DAIR? And what are the guidelines for keeping the implants and taking out the implants? So Dr. Menon, can you just explain these?
Yes, sir. So the one thing that's very obvious is if the construct or the fixation is unstable, like you can see in these X-rays, there's a loosening of the screws, the bone, the fracture alignment is getting worse as the days go by. This is not a construct that we can retain the implant. Here it's pretty obvious that the implants need to come out. Stability is the most important thing. A stable, good construct, whether it's a plate, nail, whatever we have, that has to be stable. So that in these cases, it's out. And as the infection goes on and on, as the duration keeps on increasing, we all know that it goes inside the bone, inside the medullary canal, at the fracture site. And how much ever we can debride from above the implant, we'll never be able to get to the source. And ultimately, it ends up in a non-union scenario. Now, what is the cutoff date or when does it become a non-union is still a gray zone, but it's pretty much established that the longer the duration of infection, the chance of retaining an implant become next to nothing. So again, in these scenarios, becomes difficult. And a discharging sinus is one of the hint that it's a long-standing infection. The third thing that the guidelines say, it's if it's a highly resistant pathogen, like the case sir has been showing, these cases, retaining an implant becomes difficult. Now, there is something called as a not a difficult to treat pathogen. Not a difficult to treat means for Staphylococcus, if rifampicin is sensitive, and for gram negative, if ciprofloxacin is sensitive. Now, the reason why these two antibiotics are highlighted is they have extremely good action against the biofilm in presence of an implant. So that is why if you're looking at a gram negative like a E. coli, Pseudomonas or others, you must look at ciprofloxacin. If it is sensitive, that's an excellent thing. So we have something against the biofilm if you're trying to retain. Rifampicin may not be there in your report, but if you find a staphylococcus and you're trying to retain an implant, you should try and ask the laboratory to check for rifampicin sensitivity. If it's sensitive, again, we have rifampicin to use, but there are certain guidelines for rifampicin which we'll be checking later. So if it's a difficult to treat, so highly resistant or a fungus or a non-tuberculous mycobacteria, those are ideally not pathogens where we should try and retain. So in these scenarios, try and remove the implant. And fourth is a poor soft tissue cover. So if we can't get a good source control or debride, and then if we can't cover it immediately, or at least within the next 72 to 3 to 4 days, then that implant being exposed to environment is not the best scenario. So if our setup is not equipped, then transfer the patient to a center where there is enough, there's a multidisciplinary team and reconstructive help is available, or you can do it yourself if you're experienced enough. But as soon as possible, a cover should be possible, should be done over the implant. So these are the 4 scenarios where it's difficult to retain implants. Yes, sir, back to you.
So essentially, these 4 factors are very, very important. Equally important is host physiology. There are multiple comorbidities, then retaining implant becomes very, very challenging. So where are we now? What are the points in favor? Young patient, no comorbidity, functional, previously was absolutely fine. We have excellent reduction. It is a plate which can be opened and cleaned. It is just about 18 days after surgery. The primary surgeon has taken immediate action of debridement, and we are likely to get cover. And by God's grace, we had an excellent multi-specialty approach support. Now, there are, of course, points against us. One is, initially we had an extensive soft tissue injury. So the blood supply, we are not really sure. Culture is highly resistant gram-negative organisms and resistant to ciprofloxacin. So in this case, we have several things which are for us, and then we decided to retain the implant. So what will be our tactics? Rational and timely debridement and early soft tissue cover. My plan will be not removal of implant and putting a spacer or putting external fixator, but one stage. Whatever it is, I'm going to retain the implant. And how do I monitor? I need to monitor whether infection control is there, whether consolidation is there, and generally patient is doing well or not. So what are the aims? Is it source control? No. We cannot really have source control like removal of implants, but we are just reducing the microbial load. So think of biofilms, prevent and eliminate as many biofilms as possible. All exposed implants and surfaces to be cleaned. And remember this, all of us know this, solution to pollution is dilution. So leave behind vascular tissues, don't leave dead space, start appropriate antibiotics. If need be, use local antibiotics. In most of the cases these days, world over, people have been using local antibiotics because the concentration is very, very high. Now, how do we plan debridement? The first step is getting a good culture. The culture yield has to be good. And the first step is ID specialist consult. And this is what they do. They stick a paper at the front of our file and suggest what all tests to be done and what will be the containers. I think this is the, in fact, we call this the ID consult as a first surgical procedure because they go in such details and dissect the case. So let's discuss our case. This is, he had collection under the flap on the lateral side. Now, I would request all of you to compare these two images. 3 images on left-hand side are after the surgeon has debrided, and this is when he noticed infection. Can anyone tell me something which is striking? Something which is striking. Look at the edges. These edges and these edges. Anyone?
There are a few bleeding points over the skin edges, sir, on the left hand picture.
I am little hard of hearing. Can you please speak loudly?
Okay, sir, sorry. We can see the skin edges are bleeding in the left images.
Yes.
And in the middle image, we can see there is some muscle coverage for the implant.
Right. Anything else? Anything else? So, friends, this is something very, very vital. Whenever there is infection, especially this early infection, not only the infection is around the plate often, but it is around the suture line also. When we say superficial infection, it is always around the suture line, isn't it? So if you just open the sutures or clips, you are very, very unlikely to get a good source control or bacterial load reduction. So you can see what he has done is he has excised the incisions. Can you see that? Now you will be able to compare. There are no marks of clips here. There are no clip marks here. I will show again. There are no clip marks. You can see these are after he has excised the skin beyond the clips. And that is absolutely useful. Very, very useful. So it is excising the wound, be it an open fracture or be it an postoperative infection. Excise the previous incision. And then, of course, this is where he presented to us. Again, we excise these edges. Take a very thin slice out, but all this area needs to be excised. You can see here. There were some hematomas here, muscle necrosis, but a proper excision of infected material is absolutely vital. Now, this is on the lateral side. This is on the medial side. Same thing again. We raise the flap. We clean the plate thoroughly. Wash the plate with plenty of normal saline. Whether to use dilute betadine or not is a controversial thing. We generally do not use, but of course there are many people who swear by that. So the plate is cleaned. You can see the screw holes or the head has been cleaned. Generally, there is like a gap between the plate and the bone. That area needs to be cleaned. Remember, the plate in its entirety needs to be exposed. Even if you have done a MIPO, in case you are suspecting infection, open everything. Because if you again use the MIPO incision, the middle part of the plate you will not be able to clean. So now should I open the middle incision which appeared to be clean? Now we have, there is last chance that we will be able to salvage this. So this is what we did. We closed the midline incision because it was easy. Put vac on medial and lateral side. This is a bridge therapy. I'm sure most of you know about the bridge therapy. In case you don't, we will explain after I finish this case. And that's the post-op X-ray. The culture was Klebsiella, but a similar culture pattern. And the ID's consultant gives ceftazidime avibacter, which is becoming very popular now. Now you can see the incision after first vac. So we closed the incision and did a graft wherever needed. This is at 3 weeks. So at 10 weeks, you can see a decent range of movement. And how do we monitor? This is something very important, and always we try to involve the patient in this monitoring. And this is a chart we give to every patient: date, pain, temperature, appetite, weight, and in general wound. So they keep sending this every week. So it is very easy to monitor these patients. So you can see his pain decreased significantly over a period of time. And then after about a few weeks, he said, now I'm not getting pain. I don't want to follow this chart. And this is at 6 months. He has no pain. He bicycles 10 kilometers a day. And he works in his dental clinic 8 to 10 hours a day. So friends, this is him. He just sent us this video. So the reasons for such a good result was he was a young patient, no comorbidities. The fixation was very good, done by the index surgeon. He had taken immediate action on suspecting the infection. Debridement was done immediately, and then he transferred to a unit with multidisciplinary facilities available. And then we again did a debridement. Fortunately, it was plate, so we could really clean the plates well. We could cover the implants well, and antibiotics guided by culture. Most important is motivated patient with excellent postoperative care and physiotherapy, and that is equally important. So friends, remember, read this paper very carefully. It takes at least 3 or 4 readings to understand what the authors are saying. But once you realize that, it would streamlining management of fracture-related infection would be a reasonably easy task. So, SOSTAC model or SOSTAC policy, which is a marketing model, 6 sequential steps. Don't forget to introduce or include history as well. So friends, with that, that's the end of first case. I would like to open this session. Any queries?
Sir,
Dr.
this is
Ram.
Ram Karthik here. Yes. Sir, as you have told, the stability is important to check while the...
Please start your videos.
Sir, I'm driving, sir.
Videos.
Sir, I'm driving.
Oh, you are driving. Okay.
Yeah.
Who is
sir,
that?
Ram,
Please
Ram
identify
Karthik.
yourself.
Ram Karthik.
Ram Karthik. Yeah. Tell us.
Sir, as you have told, the stability is prime to first to check whether to retain or remove the implant, sir. So, as these are locked plates, how can we check the stability? As at least 3 screws. In some of the cases, we'll have only lucency around the some screws. So, how can we estimate the stability? And one more thing is, how can you debride the under surface of the implant? Sometimes, if we pass the implant, like as I've told you, in some of the cases while debridement, I usually give the methylene blue injection to the fistula, so that wherever it reaches, I will debride all the area where it reaches, sir. Most of the time, sometimes if I get a case of MRIPO, I'll get the methylene blue seeped under the implant. How can we debride under the implant if we are planning for days, sir? And one more thing is, do you always take culture after the debridement to confirm it, and re-rape after the debridement and check the before closure? These are my questions.
Dr. Menon, will you like to take that?
Yes, so you're absolutely correct. Debriding under the implant is the most challenging thing. From what sir was showing, if it's a plate cleaning around the screw heads, in this specific case, we had actually scraped the fracture site as well. And we were worried that we had removed all the cancellous bone at the fracture site posteromedially. So wherever we could put in an artery or scoop, we went around the implant at the fracture site. We didn't bother about whether it would lead to a non-union. The idea was to debride, try and save the implant, and later on, if it led into a delayed union, we could maybe put in a bone graft at some stage. But the priority has to be going from every angle possible. It's easier with a plate, very difficult with a nail because we cannot ream the medullary canal. That's why the failure rate in nails are much, much higher. The other question was
What about
Culture.
do you take culture after the debriding?
that's also a relevant point. There are studies, there are centers which do take cultures after debridement. We don't have that policy right now. We take our culture.
Dr. Menon,
Yeah.
it's not about open fractures. He's saying that in this case, we did not take culture before debridement. We took culture during debridement. Am I right, Ram?
Yes, sir.
That
Even
means
after the
before opening, we did
debridement,
not take
24
culture.
pocket.
Am I right?
Yes, sir.
No, he's asking even after debridement, before closure, do we take a new sample to confirm whether
Pocket.
we
Is it?
debrided
Yeah.
enough?
Okay.
So the first part would be absolutely no to swabs. We'll keep hammering that point through these sessions. There is no role for swabs in empirical antibiotics because we'll simply end up getting a superficial bug, which is from the skin, which may not be the actual pathogen, and we've missed the bus. And we've clearly
Yes.
shown if you miss the bus and the infection keeps on persisting, the chance of non-unions are very, very high. So we go in, do radical debridement, get the deep samples. Again, after debridement, so far we don't have the policy of taking samples at the end of the debridement to ensure whether that last sample is negative. There are centers which do it. There are papers which do it. It is a very good practice, and probably you can implement that. But the only thing is you'll have to be careful that you use a new instrument. If you use an old instrument which has already been used, then the chance of cross-contamination are higher. So keep a separate set of 2-3 instruments to maybe take a sample at the end of the debridement.
So
And
I have a
then
little
protocol.
different way of thinking about this. And as Dr. Menon said, we have never done that. Never collected sample at the end. Basically because you reduce the load of microbes so that the body defense mechanisms can take over and antibiotics. So your culture may or may not be positive. It may come positive. What are you exactly going to do? Are you going to explore? No. So generally, at the end of a good debridement, cultures are not taken. You go clinical. If clinical you think it has to be explored, you explore.
Okay, so whatever is
Okay, sir.
macroscopic occupancy has to come out.
Okay, sir. Sir, and one more thing, what is your draping and antibiotic protocol in this type of cases, sir? Like first draping, debridement, then re-draping and rewashing of the surgeons, or you will just drape it, debride and close and come.
So we have diametrically opposite opinions. Sir will go first.
I like to do that. After debridement, I like to re-drape and do it again. Dr. Menon has visited several developed countries and nobody does that. So it's very clear that it need not be done. So we have different opinions, and as I said, respecting differences is friendship. But I personally feel, especially for joints, why joints for everything? I feel that a new set of drapings and instruments to be done, but that may not be generally very easy, but ideally, yes. I think Syed next is.
Yeah. So if I could add one more point to that, what we do is we add before we start the debridement, there's a second plastic and a draw sheet which goes under the part. After the debridement is done and the wash is given, that plastic and drape comes off. So underneath you have a clean area. The gloves are changed. So that's about it as of now. So Dr. Syed.
Okay, sir.
Hello, good evening, sir.
Good evening.
Hello.
Bolo. Go ahead.
Yes, sir. I met you in Boacon, Rajgir 2 weeks before. I had a pic with you. We had lunch together with Taneja.
Syed, let's take two questions.
Yes,
please.
Sir.
We don't have much time.
Yeah, I have a question that if biofilm formation has formed under the plate and the in between the plate and the bone, so how we will debride that and how we will get rid of the infection between the bone and the plates?
So that is relatively easy with or relatively possible with a locking plate, because very often there is some space between the plate and the bone. If it is a dynamic plate, it is not possible. I mean, whatever said and done, for there you do not do source control. What you are able to do is reduction of load. That's it. That is why if you do it early, not many biofilms have formed or they have not become mature. So with your wash, with your improving the blood supply by taking out the avascular tissues, the antibiotics are likely to reach, and the body's defense mechanism and antibiotics would take care of that.
So we have to wash the plate in situ only without opening.
Yes, I mean, you can't generally take out the plate, make chances of fracture will become unstable, and then there is no point in putting the plate because the screws may not hold well.
Okay, sir.
So taking out the plate for debridement is generally not advocated. Dr. Menon, you have any view? Dr. Thakur, sir, would you like to say something about this?
Yeah, sure. I mean, there's no point in making the whole construct unstable, but we should go in as much as possible with fine tooth or fine instruments and clean up as much material as we can from the infected side. And as you have been repeating, that the aim is really to reduce the load, reduce the burden of the bacteria, and that is achieved. It is impossible to clear every bacteria in an infected wound. It's just not possible. To feel that we are left out something under the plate is hypothetical and is also true. And we should not worry about it. Once you are done,
it may be a site of, it may be a source of infection if some biofilm remains under the plates.
Yes, theoretically yes, but then you have made an attempt to remove it, and when partially destroyed, you also made attempt to change the local atmosphere, pH, and other varieties, and other situation in the wound. That makes a lot of difference to the biofilm, and biofilm is as stable as well as unstable. Moment there is a pH difference, the biofilm gets destroyed. So repeatedly, I'm saying that it's impossible to get rid of bacteria in an infected case, but we are reducing the burden, and that will help us in recovery. A body mechanism has ultimately to win over everything and then regain the peace and quiet of the normal individual. So if you don't get under the plate, it really doesn't matter. It doesn't matter. You still be able to get rid of the infection.
Okay, sir. Thank you, sir. Thank you.
Sir, I have asked
Amin,
about.
I think you want to ask something.
Yes, sir.
Yes, sir. Sir, what I wanted to ask was, in the case that you showed right now, had the reduction not been as good as it was, just a little bit inferior to what it was, would you have chosen to retain the implant still? Or so what would be the threshold, sir, for you to remove the implant and put in a fixator, and in terms of the reduction of the fracture, sir?
Difficult question to answer. So pass on to Dr. Menon, then I'll answer.
Okay, so there is a simple way of saying that. अगर मेरा patient होगा तो the fixation is always stable. अगर तुम्हारा patient होगा तो fixation is always dicey. But that's the way we look at it.
Yes.
Seriously speaking, there is very difficult to say. If it's confusing, involve a colleague. At the first sign that things are going wrong, say you do a debridement, fixation stability may not be ideal. Give it a chance. And probably the most important thing, which is very difficult to put in slides, is the conversation and the dialogue with the patient and the relatives. That this is what we are
Right, sir.
trying. These are the pros and cons. Have a half an hour, 40-minute discussion with them. Take your time. These are the pros and cons. We're trying to retain the implant. If, like in this case, there were factors which were against us, but ultimately things went, the monitoring was important. Things went as per plan. It healed well. But if things at some point there was a discharge again, or Frank Pass at 2 months, 2.5 months, we would have had no option but to go in and remove those implants. So,
Right.
but if it's an absolutely unstable fixation, then then trying to save that fixation would not be correct. So if there is a stable fixation, you do so, you reduce the burden, then the antibiotics suppress the infection till such a time that the biology takes over and the fracture heals. I'm sure all of you have seen cases which had an early infection, the fracture united, and 5 years later the patient comes back with an infection, even though the implant is removed. So that is why the infection can never be eradicated. It's always there somewhere, but you're hoping that the biology takes over once you've done your job, and the antibiotics also help.
Right.
So, in case, see, finally you have to see whether you have an intra-articular fracture or an extra-articular fracture. If it is an intra-articular fracture, is the reduction of articular surface reasonably appropriate or not? If there is a step, then it is troublesome. If there is a gap, it may not be as bad. Whether it is upper limb or lower limb, you may accept a bit of articular incongruity in upper limb. You may not accept it in especially ankle or any of the lower limb injuries. Then finally it is cost benefit ratio. If you want to revise this, are you likely to achieve something very good or not?
Right, sir.
In case there is just a gap in the metaphyseal region, then we will not do anything at that time. But once the infection settles, try and fill the gap. I think let's go to the second case, and then maybe we can have more discussion.
The others who have questions, maybe you can put it in the chat box and we'll take it up later.
Okay.
So now the second case, a middle-aged man, you can see there is infection. He has a exposed upper end tibia, chota sa exposed, and this is at 6 weeks after injury and surgery. So going back in time, he had an open fracture following direct hit by a forklift in an oil field, and he carried these notes that he had open bicondylar fracture tibia, and as per the notes, he had an anterior wound. Debridement and bicondylar plating was done by midline incision. He developed infection almost immediately. And so the surgeon explored the wound on 10th day. They took a swab from superficial to the plate, and the growth was methicillin resistant coagulase negative staphylococci or cons. And here you can see the resistance pattern or culture pattern. And he was on clindamycin, which is absolutely susceptible. And he was on clindamycin for 4 weeks. the discharge persisted, the wound never healed, and then he presented to us at 6 weeks. Now, will you retain or remove? Yes, no, why, and what do you expect? I'll stop sharing, and then somebody else who has not spoken as yet, we would very much like them to take part. Friends, can you put on your videos, please? Put on your videos so that we'll have a little better interaction. Little better interaction. Anyone? Sukrit Dhar, you are there? Sukrit Dhar, you are there? No. Sandeep, you are there? No. Anyone who is around and not sleeping? Yes. Bhavya?
Sir, first of all, in the X-ray, I'm not happy with the stability of the fixation, sir. That's one. And this is a midline incision. And in the X-ray, in lateral view, we can see there is an anterior posterior screw.
Because that was the avulsion of tibial tuberosity, which
Yes,
they
sir.
have fixed. They have fixed. And clinically, patient was very stable. He had good range of movement.
Okay.
Quite comfortable.
Okay. And
at presentation, he was very comfortable.
Okay, sir. Okay.
Raghavendra? Sorry, Bhavya, you have not completed your answer. I'm sorry.
Yes, sir. Even the bone looks to me like little bit yellowish, like early stage of sequestrum, something like that.
Right.
So I'm not happy with the quality of the bone which is looking.
Okay. So you're not happy with the quality of bone. So you will
Yeah.
consider removing the anterior part, which is obviously yellow. Am I right?
Yes, sir.
That is what you are suggesting. Okay. Raghavendra? You are muted, Raghavendra.
Yeah. Is the yellow part the is it from the bone? Is it the bone piece we are
It's
seeing?
a small bone piece
Yeah.
and a small screw that is exposed, which is the anterior posterior screw. I'll just show the X-ray again.
Yeah.
That is the anterior posterior screw. That's the anterior posterior screw. Can you see that?
Yes, sir. The photo of the
That
wound,
is
sir?
the screw that was exposed and a part of bone that was exposed.
Photo of the wound, sir? Wound of the leg. Sir, as far as stability and fixation is concerned, the articular surface is maintained and the fixation is also stable, sir. So
you have a stable fixation. You have
except
again,
for the anterior tuberosity, but articular surface is, except for the tuberosity fragment.
Correct.
The fracture line and articular surface is maintained.
Right. Now this case, again, let's analyze. No major comorbidities. I have good position, bipolar plate, state of the fracture, good alignment, poor soft tissue cover, consolidation too early to say anything. There's no bone defect. Microbiological diagnosis, cons are not very aggressive, and he has a moderate sensitivity pattern. That means there are good enough antibiotics which are useful, correct? Now, what do I want? I want all this. I want him to get a fantastic result, correct? So my aim would be DARE, debridement, antibiotics, and implant retention, correct? So my aim was debridement, and then I thought I must do a removal of that screw, tibial tuberosity screw and tibial tuberosity, and a good soft tissue reconstruction. If need be, put local antibiotics. If need be, if I have enough space, I will put local antibiotics. So me and the plastic surgeon decided to do a flap. This is 2008, friends. And this is importance of involving ID specialist. And our ID specialist said that no way. I stopped the presentation here. He said, no way. You will not be able to save these plates. You will not be able to, come what may, you will have to take out these plates. He said, I do not believe this culture report. I do not believe this culture report. Anyone now? Said, I do not believe this culture report. So I'll again go back to the presentation. This is what I had planned. So he said that, remember, methicillin resistant organisms are skin organisms. Now, it cannot be only cons. He is bound to have contamination with soil or water because he had an open fracture following a direct hit by forklift. Forklift is used in oil fields. It is used to collect mud. So he said the hypothesis was pathogens are identified superficial to the plate. While here, especially when the infection has persisted and he has had an open fracture with direct hit by a forklift, then they are likely to be located deep inside the plate. So it is incorrect localization and therefore incorrect identification. This identification may be proper, but the localization is not proper. So you need to have another bug, which will be deep inside and which will be one of them. These are the soil organisms and water organisms, and they are likely to be embedded underneath the plate. So take out the plates. Now patient was very comfortable and I had no heart to take out the plate. So I explored once, cleaned. I wasn't happy. And I just dilly-dallied the removal of plate for 12 days. But by that time, he had started becoming a bit unstable, started getting some pain. So again, my situation analysis is changed because my ID consultant had challenged my microbiological diagnosis. So after 12 days, I re-explored. You can see the anterior cortex is totally gone and the entire upper end tibia could just come out with artery. It was absolutely soft. Both the plates were loose. There was destruction of upper end tibia. And here you can see deep inside. That's the tibia. And deep inside was a dirty granulation tissue which grew enterobacter. That is gram negative. So you must know, you must think in your mind how the microbes have reached the body and fracture site. Because a lot depends on from where they have come. Now what do? I have a clean wound post-op. I have put an external fixator. So again, I have to have a situation analysis. I have a joint spanning fixator, which is not very stable. I have a large soft tissue defect. I have a large soft tissue defect, a large bony defect, and I have no patellar tendon attachment because I had to take out the tibial tuberosity. In addition to cons, I have gram negative with a moderate sensitivity pattern. So all in all, I'm not in great shape. So I have to have infection control and soft tissue cover as early as possible, right? So I need to do a good debridement. I need to do a good soft tissue reconstruction. I have done debridement, but rest all I have to do. I have to have soft tissue reconstruction, bone graft, local antibiotics, and systemic antibiotics. So the plan of action, the first step is flap. A local rotation flap was done over antibiotic balls. This is at 8 weeks. We have good bone formation. Moment you give a good soft tissue cover, good blood supply, you can see the bone formation has already started. That's at when we did the flap, and this is just about 8 weeks after the flap, bone formation has already started. Now I put a tricortical graft here in the center just to support the articular surface. And this is at 18 weeks. He has started partial weight bearing. This is at 2 years. Funnily, I didn't do anything for the tibial tuberosity. The patellar expansions or quadriceps expansion found their way somewhere. And then you can see as a good knee range and good extension power. And this is at 13 years. So what is important is think like Sherlock Holmes. How have the microbes reached the body? Otherwise, you will land up with a situation like this. Microbes are deep inside. You take a culture from superficial to the plates and you think that you are treating with appropriate antibiotics. This is at implant removal. This is at debridement. This is at 1 week after the flap. This is 8 weeks when we took out and put a bone graft. This is at 18 weeks when I started with partial weight bearing. This is at 2 years. He returned to his job in Gulf about 8 months after the injury and started doing everything. And this is at 13 years when you can see the bone is totally reconstituted. So bone occupies the envelope. It is our duty to give a clean, uninfected envelope. So friends, please read this paper. So stack, situation analysis, objective, strategy, tactics, actions, and control. Do not underestimate microbiology and most important, the history. Again, I will reiterate, the construct has to be stable, the reduction has to be good. Otherwise, we need to take out the implant. Duration, earlier we explore, better are the chances. A decent culture pattern helps. And we must have a good soft tissue envelope for fracture as well as implant. Don't keep your implant exposed or your fracture exposed. So finally, friends, this is a very nice paper which all of you should read. Maintenance of hardware after early postoperative infection. And what they have said that in addition to all this, intramedullary nail is a challenge for retaining implant, because just now somebody had said, how do you debride nail? Yes, you cannot. You cannot debride the nail completely. So chances of failure are quite high, and open fractures, because here the bone, the contamination may be driven deep inside, and we saw that case. Now, after we do everything, after we follow, how many implants fail and how many are retained? So they analyzed 123 patients from almost 10 different setups in United States. All of them were detected and appropriately treated at 6 weeks. The implants were retained. Culture-specific antibiotics were given after debridement. And the results were overall failure rate was almost 30%. So when we talk of dare and keeping the implant, it is a very challenge. Only in about 70% you are likely to succeed before the fracture heals. Now they had 7 patients with chronic amputation, chronic osteomyelitis, and as many as 7 patients who underwent amputation. So that's a very, very high percentage. And the predictor of failure were not smoking or difficult species or location, but the predictor of failure was intramedullary nail and open fracture. That is very, very important. Finally, after healing, in as many as 26 patients, they had to remove the implant. So almost 25%, they had to remove the implants after the fracture had healed. So overall, if you have an implant-related infection, and even if you address early, you have 50% chance that the implants will have to be removed. about 30% when before the fracture heals, and at least about 20% after the fracture heals. So friends, that I will stop sharing here. If there are questions, we will address them. And otherwise, Dr. Thakur will discuss what we learned today. Any questions?
So there was a question, couple of questions in the chat box as to the timing of antibiotics, and second, healthy versus unhealthy cancer bone. How do we decide?
Okay.
Timing of antibiotics, right?
Yes, timing of antibiotics.
Timing antibiotics. Now, generally, 6 to 12 weeks is what is described. If you retain the implant, then longer duration. If you have started, if you have rifampicin sensitive bug, then you start rifampicin, and that is generally given for 6 months or even later. Rifampicin is to be given only if you retain the implant, and it has to be started only after the microbial load decreases. That means you start after about 2 weeks or so, 10 days to 2 weeks. It is given in a longer, larger dose, about 600 milligrams at least, and to be given for at least 6 months to 12 months. Or some people stop at 3 months, but generally people generally continue for 6 weeks. 6 months, sorry. It is never to be given alone. It has to be with another antibiotic, and good monitoring is needed. Otherwise, the other antibiotics are generally stopped at 6 to 12 months. Now, when I say 6 to 12 months, that means finally you are suppressing the infection till fracture heals. Aim is suppress it till fracture heals. So if the patient does not have clinical signs and symptoms which need re-exploration, then you keep antibiotics. If the ESR CRP is high, then generally antibiotics are continued for 3 months. The other question?
Healthy versus unhealthy cancerous bone, how do you decide?
You will take this question? Or you are in a... Dr. Menon has to leave for Asia Pacific Orthopaedic Conference. So I'll take this question. Okay. Now, if you have noticed, when you take out the bone graft, you have some resistance of the cancellous bone, correct? There is some resistance. Whether when you take out from the upper end tibia or from iliac crest, you have some resistance. You really need to use a gouge to take it out, right? While if it is infected, you will realize that you can take it out very easily. Number two, a good cancellous bone makes a noise. Generally makes a noise. A thick, good cancellous bone makes a noise. It is difficult to remove. And of course, on appearance, you can see a red cancellous bone. Soft infected cancellous bone, A, the color could be yellow. B, it can be very easily removed. And C, it would not make any noise. You may be able to take it out with just an artery. A normal cancellous bone, you will not be able to take out with an artery. Though all these are subjective, but with experience, you will pick up. And of course, one should tend to over remove a cancellous bone which is not supporting the articular surface. Then you can over remove and be sure.
So, I'm in the cab, I could hear clearly, but as far as the duration of antibiotics, were you mentioning 6 to 12 weeks or 6 to 12 months? There was one doubt about that as well.
Okay. So
So it totally depends on case to case. There are several cases where the fracture healing is progressing well, but there is evidence of infection. There is a sinus. Then people have continued it for 12 months also. So it is not a cut and paste solution. You need to decide depending on which way you are going. But if the thing is absolutely quiescent, no problem at all, You are very happy with your debridement. The fracture X-ray also is improving. Then you can certainly stop at 8 weeks.
Sir, and this question hasn't been asked, but I think it's something that you could explain. These early infections, very often they would be on antibiotics. One, should they be on antibiotics? Two, if they're on antibiotics, would you delay the debridement?
Means if the patient is on antibiotics in early postoperative period, would you delay the debridement? Is that the question?
Yes, sir. Yes.
Okay. So in our setup and in most of the setups across the developed countries, as well as many institutes, the prophylactic antibiotics are given for 24 hours. Neither oral or nor injectable are continued beyond 24 hours because that is generally more than adequate for as prophylactic antibiotics. Then if you notice infection, two things happen. One, it is not necessary, and two, and more important, in case patient gets develops infection, you are able to pick up early and able to solve or sort out the infected portion and likely to, which may lead to retention of implant. But if you suppress the infection, it may come up later. You have a fully formed biofilm, which you will not be able to debride, and chances of failure are very high. Coming to the next question is, if the patient is on antibiotics, will you stop antibiotics and then address or then do the surgery to improve the culture yield? Now, as far as that is concerned, generally 2 to 3 weeks of stopping antibiotics are useful. However, there are exceptions to this. You want to save implant, you want to save limb, you want to save the joint, and you want to save the patient. In case any of this is likely to be threatened, then there is no point in stopping antibiotics. So friends, it's 1 hour, 20 minutes. I think everybody is tired. All of you are tired. So may I request Dr. Thakur to tell us what did we learn today?
Thank you. See, whenever a patient whom you have operated a fracture, he gets infected, it is a devastation, not only to the patient, but is also to the surgeon. We often underestimate the panic it strikes in surgeon's mind. He loses his usual calm and comfort and is in a bewildered state. Lucky if he has a colleague who can help and advise him, otherwise, the single handed person always gets lost and stops thinking radically. At that point, one requires a mantra or a sutra which will guide him to go how to analyze the situation. And that is what we learned today, that SOSTAC analysis, that you analyze the situation and then find out what do you want to achieve, lay down the planning and also how to do about it, and go ahead and do that. Having done that and resolved to eliminating the infection for the time being, you observe him that it doesn't come back. All this we learned today in these two cases. In the first case, this index surgeon was very well oriented to managing infection. He rightly opened up immediately and debrided whatever he could do at his own place, but he also understood his limitations and he transferred the patient to a place where more help was available. The more help was available, more advice was available, more experience was available. With that, the team, the index surgeon, as well as the surgeons at the tertiary hospital could help the patient, restore him to his original health, and come over the mishap that had fallen on him during that infection phase. That was all done because the SOSTAC analysis was followed, and that is how the victory was achieved. In the second case, it was done in the injury was in the oil field. the surgeon was not that oriented in handling the infection. He did not do a thorough second-hand job. Probably he did not do the first-hand job properly of debriding the dirty things. He could have possibly waited for a day or two and redone the whole thing, debridement, and then fixed the fracture. But depending on his understanding of the situation, he probably just went on and fixed the whole thing. As a result, in 2 weeks' time, there was infection, and he was in a foreign country, so it took time for him to be moved to India, where he then ultimately landed in the right places. And then the situation analysis was undertaken, which ultimately led to a good union. So, by and large, what we have to see that this is like entering a chakravyuh and coming out of that chakravyuh. Once you face this infection after a fracture, and that too a fracture that you have faced, you must calmly analyze the situation and follow the SOSTAC analysis, and then bring yourself out of that tricky situation. Also help your patient to restore his good health in the shortest possible time. Our thing about this antibiotic, I think each one of us who are handling fractures should reorient ourselves for use of antibiotics. In this course, we will, of course, discuss how the prophylactic antibiotic works. What is the principle behind it? Once you grasp those, you will yourself not use the antibiotic beyond 24 hours. Because beyond 24 hours, giving antibiotics makes no difference. That I don't want to enter that discussion at this stage. It will come to us later, but that is a major issue that we'll be considering that way. So, by and large, our main achievement today was analysis, the scheme to understand the complex situation and how to analysis. That is the today's take-home message, which you should remember for rest of the course as well as the rest of your practices as well. Dr. Agashi.
Thank you very much, sir. And thank you all. Syed, I'm sorry for cutting you short, but then it is little unfair for others, towards others. That's why we'll stick
It's okay,
to,
sir.
we'll stick. At the end of the session, then we can have a small chat. No problem. But during the session, it is always better to be professional.
Okay, sir.
Okay, friends. Thank you very much. And
Okay, sir.
we'll go back to Ortho TV. We'll meet on next Friday. Bye-bye. Bye, everybody. Bye. Bye.
Thank
Good
you,
night.
sir.
Bye,
Good night,
everyone.
sir.
Thank you, sir.
Bye, Dr. Ashok.
We
Bye-bye.
would give
Thank you. Thank you.
OT immediately.